Okay, hello to everyone who's joined the webinar. A warm welcome to everyone, and I wanted to thank you for joining our Autism Care Pathway webinar, where we're very excited to share the new evidence on making a meaningful impact to autistic individuals and their families. And we're really excited that we had over 400 professionals and carers registering for this webinar. I realised there was a slight discrepancy in the start time, so this is just an opportunity to introduce yourselves on the chat function. So if you click on the chat at the bottom of your screen, and if you'd like to just write your name, your role, and that would be really helpful. Then everybody who's participating can see who's joining the webinar. And please feel free, we encourage participation. It would be very nice if there could be participation as we're speaking and as the presenters are presenting on that chat function. So firstly, if you have any practical difficulties or need any guidance or lose connection, please email our team on info@pacttraining.co.uk. Your mics should have already been muted, but if they're not, could you please click mute? And then if you are wanting to speak, particularly during the Q&A section, you can click unmute while you participate. There will be question and answers, so feel free to post your questions on the Q&A tab. That's a separate tab from the chat function, and you can post your questions on this tab as people are presenting. We do have a question and answer section at the end, and we'll try to answer some of those questions, but any questions we haven't answered, we will consider the responses and post them on the PACT website. A full recording of this webinar will be available on the PACT website. So the website is www.pacttraining.co.uk. And you will find further information on the website about PACT and contact email there as well if you want to contact us at any point. So I'm really delighted to hear Professor Jonathan Green presenting on the new scientific evidence that supports the development of an integrated autism provision from early identification and a care model from early infancy through to school support. Jonathan has pioneered forward-thinking and world-leading science dedicated to improving the effectiveness of autism care. And as we'll hear, this is included in the national guidelines to make it accessible to all children and families. It's an exciting time when we now have the benefit of a cumulative scientific evidence conducted over 20 years. And this includes new models of early identification, the potential efficiencies of digital technology, and a very family-focused intervention for parents and their children to promote sustained development. So the vision is to transform the science into practice and things that can be practically embedded within existing autism care services. And this vision is a shift from a reactive to proactive approach, where early support can make significant improvement in child developmental journeys. And what's striking about the science, and it's been a great privilege to be part of the scientific team and this accumulative evidence is that there are an infinite number of individual variables, and to have an umbrella term may not, accurately represent the range of individual variables. So what works for one person may not work for another. But what, importantly, these large-scale research trials and their follow-up studies give us is provide guidance on the process. And the process which has been illuminated is the importance of a balanced alignment of the interaction of the individual child profile with the adult, supporting adult. And the other important principle that comes to light is facilitating child agency by giving the child the power to be understood and to understand others. I'm also really delighted to hear two presentations from professionals who are working in the NHS and giving us examples of how they've embedded this new autism care pathway into their existing autism services. And this has been over building a service over several years. And I look forward to hearing about the feedback, their progress, and their vision for the future, how they would like to continue to progress this service. Because this gives examples of the science being weaved into existing practice. It's been proven to be feasible and proven to have added value. And so I'm really looking forward to hearing from our two presenters on the NHS delivery. So this is our agenda for the day. And I'm now going to hand over to Jonathan Green to give us the first presentation on early support for neurodivergent children and the new autism care pathway. So I'll hand over to Jonathan now. For those who just joined us, please feel free to add your name and your role, where you work, on the chat function. It would be nice to know who's here and who's participating.
Okay, hi Catherine, hi everyone. We're starting a bit early for my presentation, Catherine, but you're happy to do that?
Yeah, that's fine, yeah.
So hi everyone. It is a real pleasure to be here with so many people who've been interested to join the webinar, and look forward to telling you about this, and particularly perhaps to have our some conversation together that and I hope that we can have good Q&A responses. I know it's not so easy on a webinar, but we'll do our best and see if we can create a bit of a to and fro dialogue around the kind of ideas that we're going to be presenting to you, discussing with you this morning. I'm going to kick off by outlining the principles of this pathway idea that we have developed and tested, and which grows out of the work, as Catherine said, that we've been doing over 20 years in developing quite a new kind of model of intervention support for autistic children and their families. And then I'm also going to present some of the early experiences that we've had in implementing this within the NHS in parts of Manchester, and that'll lead on to my colleagues talking about how they've developed this elsewhere in Greater Manchester and in the country. So I wrote about this back in 2019, and I think since I originally wrote this initial kind of position paper, as it were, the situation has amplified even more. But these were the challenges that I set out for us who work in clinical services within autism. And I think you who are joining us today will probably agree with this situation. I mean, if you don't, say so, but this seemed to me the situation that we find ourselves in. And as I say, since 2019, the situation has only, I think, amplified. One of the things is that our current clinical response to presentations of autistic children and young people and families who are concerned about their child's development has been basically too late, reactive to problems rather than anticipating them. Importantly, poorly evidenced. And I'll come back to the issue of evidence-based practice, which sort of informs this whole webinar, but really, and obviously I have this is my position on it, but evidence really does matter, and it does make the interventions that come out of it that are tested more efficient and more effective. But the current clinical response has been poorly evidenced, and it's also importantly episodic, by which I mean that there's this idea which really comes from other aspects of healthcare, that you have a problem, you do a time-limited intervention because you don't feel you've got enough resource to do anything longer term, and then you discharge the patient, as in the health service terms. There's an episode of care, and that's that. And those episodes happen too late in development. So the other challenge has been that diagnosis has been used as a gateway into care, and the diagnostic process is carefully done and importantly done, take time and specialist consideration, and that inevitably leads to escalating wait lists and a diagnostic bottleneck. And I think we all know about this, and there have been plenty of reports and national guidance documents, etc., documenting how this has ballooned, especially over the last few years. And then and that's been with the expanded awareness of neurodiversity and autism. And the extraordinary figure, which is around at the moment, is that at the current time, something like 80% of CAMHS referrals relate to neurodiversity of one kind or another and autism. I mean, it's extraordinary. So services are struggling with this. I think everyone, all of you on the call who are involved in services will agree with that. And we need an efficient way, an evidence way, and an effective way of managing this. So what I've proposed in this position paper was that we need to think of autism as developmental and enduring for a start off, and the support needs to reflect this. There's no point having episodic care in a condition that is an enduring state of being and state of development, which in itself doesn't always need care, but when it does, we've got to give the appropriate support. And I propose that we need to link detection and care so that we don't have people sitting on waiting lists, families sitting on waiting lists, worried about their children without an answer, sometimes for 1 or 2 years. without any support, just sitting on a wait list. And then we need more evidence kinds of care, particularly for interventions, therapeutic supports that are focused on family and have shown to have long-term developmental effects. And the importance of that is that if we're going to put our resources into doing something, we need to do something that's going to have a long-term and an evidence long-term effect. That is, we've got finite resources in the health service. We have to use it most efficiently to things that are going to make a difference to long-term development and family functioning. And there are lots of kind of ways of organizing service models that we need to develop to deliver this through development. And one important principle when one looks at enduring healthcare kind of service models is this idea of self-management. And it is that the person who's experiencing the issue needs to have be empowered to understand and look after their own care. And I think this is well recognized now and important. And for us in the autism space in early childhood, this means empowering families to understand autism, to be able to empower to work with it effectively. And that's a key to the kind of intervention that we've developed. So why the other sort of big shift in this pathway model that I'm going to present to you is to go pre-diagnostically and what we call preemptively, sort of anticipating things in development rather than reactive to problems. And this is a big shift in mindset, which I know from experience, really has to be advocated to both practitioners and service managers for why we should do this in a developmental sense. And my argument for this, and I hope that you'll see how this is worked out in practice, is it's more efficient to do this because we can link early detection to pre-diagnostic support and care. And I'm going to show you how we can do this. It's more effective if we do this because families are happier earlier. They're not sitting stewing on wait lists. They have more increased resilience, which I hope we can show you. And children have enhanced early development from the earliest times, and they're not sitting around waiting for developmental support. So early is really better in this way. But we need to show that with evidence. There's no point just stating it as an aspiration. We need to show how this can work efficiently. The other thing, which is, healthcare is not just about money, but money is important in the health system. And we have shown, and it's very important to show, that this kind of approach is actually cost effective. So we have, of the two interventions that I'm going to propose to you this morning, the I-BASIS and the PACT, we're going to talk about both. We have cost effectiveness studies, independent cost effectiveness studies on both of them. And, these are really important results so that this study in Australia of I-BASIS showed that if you invest every dollar you invest in this kind of early anticipatory support, is shown to save $3 by middle childhood in reduced service use. That's an important advocacy argument for why we should shift our approach to be more preventative or proactive or whatever you want to say. And in the PACT intervention, we've also shown that the PACT is cost-effective into middle childhood in modeling across its use in Europe. So it actually works both as a sort of clinical level, as you'll see, but also at a cost level. So intrinsic to this pathway is the kind of support model that we're talking about here. So I'm just going to spend a little bit of time describing this. And it's family focused, and it's based on increasing family resilience through parent mediated intervention. That's the formal way of putting it. And we use a video feedback technique in order to do this most effectively in a way that you'll see. But the important idea of the model, as you'll see as we develop the slides, is that we don't work directly in this model with the child at all. So this is really a radical difference from the way that specialist professionals have worked in the past with autism. We're not working directly as professionals with the child, we're working with the family through the parent. And the wager of this is that by doing that, we instigate a cascade of effects within the naturalistic developmental process in the family, which actually benefits the child as it comes through. And that is a wager because, you know, it's not necessarily, it might be a nice idea, but it's not necessarily obvious that doing that would actually impact child development. And we've had to test and show that in the science we've done, as I'll suggest to you. So the idea is that we work with parents, that we introduce this cascade of effect between parent and child, and then the other bit of the wager is that the child will then make use of this change in the family and generalize that new learning out into the world beyond the family. And that is another big wager about how these effects could generalize. And these are important things we've tested in our studies. So it's this cascade effect that we're after, based on the idea that early interactions, communications between young children and their caregivers are so important for so many aspects of later development in terms of feelings, trust, relatedness, social motivation, mental health, well-being. We know that this is the case from many, many years of developmental science research in neurotypical development. And the key things about the interactions are about this idea of attunement and how the parent-child interaction sort of fits together and is responsive. The big challenging question is, how does this work when you have neurodivergent development? What happens to the transactions, the early transactions with caregivers, and what effects might that have on later development? And this leads us to think that our intervention supports should be with the parent to help them, empower them to optimize these early interactions, their understanding of the child and these early interactions, attunement, goodness of fit. It's important to emphasize that this is not a parental training. There is no assumption here or implication that there is anything wrong with the parenting. It is to acknowledge the situation that parenting a neurodivergent child for any parent has challenges, because the development and the communication can be difficult to make sense of for regular parents trying to do what we all do as parents intuitively. And our supports aim to help parents do this intuitively, to be the best parent they can be in the situation. And the wager is that we can help them do that, and that will then lead to positive outcomes downstream for the kid. So that's where our intervention is directed, at the parent, just because they're the people who are best going to be able to impact this social environment around the child. So just to give you an example of how the video feedback works, this is the sort of core technique that Catherine first sort of developed in her practice, which really been the core of the way that we've developed this kind of model. And what we basically do is take a videotape of a parent with a child in a naturalistic context with various, this is just one example, there are various sort of setups that we would use. And we take the video and then we play that video back with the therapist and the parent. So this will just give you the idea.
Stop. Oh, yes. Together. Push. Stop. Nathan, stop. Say Pipo. Pipo. Where's he gone? You found me. You're so clever. Clap hands.
So in the course of the work in both iBasis and PACT, that kind of video material is then played back between the therapist here and the parent who you've already seen in that videotape. And this is how it looks looking at that particular clip between them.
Yes, the one where he understands Nathan. Yeah, that's, and he got quite excited when I stopped it. Yes, the first time you stopped it. Yeah. I think that's right at the very beginning, and that's something that's really quite interactive because I think he realised I did that, and it made the game more fun. Yeah. Well, let's watch that bit again and see. Yeah, just see what it is. Let's have a think about what made it interactive. What were you doing? What was he doing? What signals was he giving you? Yeah. So that that's what I need to read. This means he wants me to be in this bit. Yeah. Yeah. Let's see what he does. It's always quite familiar.
So what I want to emphasize your attention to here is the style of this and how the parent is making their own discoveries within the video. It's not that the therapist is telling them what to do, how to be. This is not coaching, and this is not sort of psychoeducation. It's not modeling. It is really a mutual exploration of the tape so that the parent starts to understand their child and their interaction with their child in real time, watching the video of themselves. And we know, all of us who've done this kind of video feedback thing know how powerful this is for one to make one's own discovery. And it's the fact that the parent is immersing themselves and making their own discovery with the therapist's support and help, of course, that makes this such a powerful technique for adult learning, if we put it like that, and parent recognition and change. So important to say, particularly in the current context of the neurodiversity debates and environment that we're in, is that this kind of model is not about removing neurodiversity. I hope that you can see from this initial presentation that what we're doing here is actually quite the opposite, that we are attending to being interested in valuing neurodiversity. I'm trying to understand it, and by responding and making best understanding and responding to it, enhancing that neurodiverse development. It's not about saying we need to replace neurodiverse development with something else. It's about making the neurodiverse development the best it can be through this kind of social engagement, attention, recognition, and validation. In essence, it's validating neurodiversity. And that's, in principle, what you'll need to know, and what you'll want to know is how does that work in practice. So the two interventions which have the same basic principles behind them that we're going to show you, the iBasis is this early support that's designed for babies, initially infants, pre-diagnosis, who are showing early signs of an autistic trajectory. It's based on home-based delivery, manualized, it's neuroaffirmative, and it uses this video feedback kind of technique that you've seen, using 10 home-based sessions over about 5 months. So it's that sort of length of intervention. In terms of a lot of autism interventions, this is very low intensity. And already said, it's collaborative and strength-based, basically, and parents are asked to do these daily practice plans, building on the video feedback work with the therapist. And as the parents get into this, they're getting increasingly autonomous in how they deliver and how they integrate this work into family life. And that is such an important characteristic of this, because of course, if parents do that successfully, from the child's point of view, if you want to say this, they're getting 24/7 therapy because they're getting this adapted environment all the time. And that's what makes this kind of style of work, if it actually is effective in changing that, so powerful and so long-term in its effects through development, as you'll see. So we've done a whole series of clinical trials on this kind of approach. And the most extensive on this infancy support is this one in Australia, over 100 children followed up until 3, published a few years ago in JAMA Pediatrics, which is a big American journal, and showing clinical trial outcomes. The PACT intervention, as I say, conceptually related, in the way it's been formulated initially was clinic-based in its operation, and that's how we initially tested it. It can be used, however, at home and in education. We've done it in education as well. It can be delivered online, and particularly, of course, like so many during COVID, we generated the online capacity for this very successfully. And actually works tremendously well online, as my colleagues will I'm sure tell you later. And this is slightly longer, so PACT, it varies how long we do it, but over between 6 and 12 months, around 12 sessions, that kind of time. And it can be applied. The way we've mainly done it is preschool, but it can be applied up to about 10 years of age. And it includes also the parent practice. And again, we've done a number of trials of this work with long-term follow-ups. And this Lancet paper in 2016, which many of you be familiar with, presented our long-term follow-up into middle childhood from preschool support intervention. And that is the longest, and it remains the longest trial follow-up of any autism intervention. So what are the effects? I haven't got time to go into the detail of the science of these, but they're all available on in the papers. What I want to emphasize here is the range of effects that we get downstream as the result of this kind of intervention. And this is the crucial evidence that allows us to be confident that we can promote this in a pathway that I'm going to describe to you. So initially, we do get changes in parent synchrony. This is our measure of how effective the video feedback's been in really allowing the parent to tune in to the kid and respond to them in a way that's appropriate from tuning in. And this synchrony is the first thing that we need to show, that we've actually made that change for the parent. And that proves to be extremely effective. So in all the trials we've done, there's never been a trial where we haven't shown this, that the video feedback we use is extremely effective in helping parents of all kinds tune in this way. And it's important to emphasize of all kinds. So initially, when we started this, people thought, well, the sort of educated parents will, high-income parents will be able to get hold of this, and maybe not others, etc. Absolutely not true. We have shown that this works across social class, ethnicity, cultural difference, and also in parents. And of course, there are many parents in this context who are autistic or have autistic traits themselves. And we've shown it can work with all those groups. So this is really a universal kind of effect. Then we show that the children, as a result of this, increase their social motivation and their engagement with the parent. And that's the key shift that the child makes as a result of this therapeutic approach. And remember, we don't work directly with the child at all. So this is all the result of empowering the parent and changing this attunement. And as a result of that, the kid starts to get more socially motivated, more engaged, more active, more communicative. And we measure that objectively using sort of video coding. And we show that consistently. We've never not seen this effect. So, which is an extraordinary result in across all the different cohorts we've done this in and cultures. And then we also show that the children who do this in the dyad with their caregiver also generalize that out when they interact with others, strangers, in this case, in terms of the trials, in terms of researchers, who when we test the children in assessment settings, in terms of all sorts of aspects of their behavior, including autistic behaviors. And these, we show changes in these. So this becomes a generalized effect outside the family, which in itself is an extraordinary result, actually, and says a lot about the way development happens. We also show improvements in child language as reported by parents. But when we do structural language tests in the lab, which are much sort of less sensitive to change, actually, we don't see an effect. We show improvement in child social communication and adaptation in a broad sense, both in home and school, and family functioning. And in one of our studies, when we did this in school, we showed improvements in challenging behavior. So this is by the end of therapy. And then importantly, when in PACT, we did this long-term follow-up for 6 years into middle childhood. So this is 6 years after the end of therapy. We showed sustained effects. And this is a striking, pretty and robust and pretty extraordinary result. So that 6 years after the end of therapy, we were still seeing treatment intervention specific improvements in child social initiations in the dyad. They'd sustain that over all that time. Optimized autistic related kind of behaviors, family functioning improved, and teacher reports of their adaptation in school actually different if they'd had the preschool intervention than if they hadn't. So this is a long-term developmental effect. The parents show a sustained increase in their well-being, and we got an effect which didn't reach statistical significance, but it did look quite convincing in the data that children were less anxious, or a trend towards that. So these are broad-ranging effects on child outcomes done in sort of rigorous assessments within the clinical trials. And that gives us a lot of confidence that this kind of approach really is making a difference within intervention. But then we have a lot of qualitative reports back from families, and you'll hear a lot more of this later in the morning. And these are really striking too, because, you know, it is how the parents and the families feel about their child and about their own parenting that it really is hugely important in terms of the sustained effect of this kind of model. And what's consistent across the reports that we get from parents, and as I say, you'll hear a lot about this from my colleagues, is how this kind of approach builds relatedness. It builds a sense of connection between the parent and the child. And we all know as parents that, you know, that is the crucial core aspect of parenting, early relatedness, and feeling, good feeling, well-being in the family. And we get this consistently, that parents start to feel this as they start to get this attunement in the dyad. So that's the approach. Now I just want to give you a sense of how this can be incorporated into a pathway model that is applicable within our current health systems, and that's important. I mean, there's no point doing this unless it's pragmatically realistic within our health systems. And I wrote about this model with colleagues a few years ago in 2022, about how we could incorporate this kind of approach into an early care pathway. And this is the pathway. It really starts, the principle starts with early detection, a stepwise monitoring approach to pick up early neurodivergent autistic trajectories early on in development, so that we could then link that with a care straight away with care, so that we're not making an identification and then having people sit on wait lists. We're actually linking early identification and early care. And that, I think, is a key principle, which then leads to a sense of family support and all the early intervention, early developmental impacts that I've shown you from the trials. This is the early work in development that we're focusing on today, but the full pathway also includes a whole load of other long-term supports. So this we consider foundational. If we can get this family-focused, family empowerment resilience in place, that is going to be foundational for the later developmental care of the child. But that doesn't mean families and children are not going to need further supports as they go into school, as development proceeds, as they go into adolescence. And we all know that a lot of these children are vulnerable to co-occurring mental health problems, etc. And we need ongoing supports for them. So you need a mechanism to build on this foundational care into the longer term. We're not going to talk about that so much today, but it is part of the general model. It starts with this foundational care that we're talking about. It doesn't end with it. We need to continue the support of families in an efficient way, because and this isn't endless therapy. This is about being really efficient with how we target care only when it's needed. And it's on the assumption that if we've done this early work with families, they won't need so much. They'll be more resilient later on and won't need so much later support, but they will need some. So just in a little bit more detail, this early work is about tackling the diagnostic bottleneck. So we need a surveillance tool that's going to pick up early likelihood or concern around neurodivergence or early autism development. And what we have used is this instrument called the Social Attention and Communication Surveillance Instrument, or SACSR. And this is a key component of the pathway, which then needs to be linked in with this early care that I've already described in IBASIS or PACT. But just to focus on this surveillance bit for a moment, it's important that we have a surveillance instrument that works empirically, that is robust, easily usable, but also shows its value in not over-diagnosing or over-identifying, not under-identifying. In other words, it needs to have what we call specificity and sensitivity. And there's a lot of work that's gone on into this particular instrument, the SACSR, and it has, in my judgment, the best evidence for this in the world now, and that's why we want to use it. It was developed in Australia by Josie Barbaro from La Trobe in Melbourne. And there's lots of published work on this for those of you who are interested in the science. So this JAMA Pediatric article in 2022 was summarized a lot of this early work. And the important thing here is the sensitivity and specificity is really good. And it doesn't overdiagnose children who are actually neurotypically developing. And you'll probably be familiar with an instrument from America called the MCHAT that's been used for many years. And actually, there's independent work that suggests that, I mean, MCHAT's fine, but what we call the positive predictive validity, which is the sort of key metric that we use, is better with SACS than with MCHAT. And this is an independent study. It was published in this year, which suggested that. So we think the SACS is a good instrument to use. You'll hear from my colleagues about how it works in practice, and I'll give you a bit more information later, but it's simple. It's used by health visitors and community workers, checklist approach, but also observation. They need training in it, but it works okay. The important feature of the pathway at this point is that, as I've said, we link this SACS-R identification to therapy, which usually, it depends on the age of the child. If they're under 2, then it's into this I-basis. If over 2, then it can be into PACT, and PACT has been used in this way. What's important about this pragmatically is that when we do this linkage, so remember this is pre-diagnosis, this is a surveillance instrument that we pick up likelihood. It's not diagnosis, it's a likelihood, and we put the care in at that point. Right? This is the radical bit of this. And the point about that is that the therapist gets to know the family over the period of 5 or 6 months or however longer as they do this support. And they are then in a great position, and they will pretty much know at the end of that time whether this child has a diagnosis or not, to be honest. And at the very least, they're in a good position to contribute to the triaging and formal assessment options that can then happen. And what we feel pragmatically is this is a way of streamlining what we call stepped assessment and diagnosis. So not every kid is pushed into a neurodevelopmental assessment pathway where they're sitting on a wait list for specialists to look at them. This is a much more nuanced, graded, proportionate approach where we actually deal with the assessment piece at the same time as we're dealing with the support piece. And those of you listening who haven't experienced this may have lots of questions in your mind about how this could possibly work in practice, and I'm going to come to that. But the idea is that this will enable us to do a much more nuanced, efficient, effective assessment diagnosis process. Doesn't mean we don't put diagnostic assessments in, but they don't need to be with everyone. And please, I think I'll power through to the end of the slides, but I'm sure there'll be questions here. Very happy to answer them at the end. So there's this stepwise monitoring, surveillance, assessment, linked care, early foundational support with the therapy, and then this long-term support, as I've said, which we're not going to talk about so much today, but we need, it doesn't mean we don't value it. We need these specific treatments for and supports for co-occurring conditions like anxiety, depression, ADHD, OCD, and these need to be part of the service provision, and they need to be properly designed for autistic people. Delivered by appropriate specialists. So this is part of it, but it builds on this foundational care. So that's the elements of the pathway. We've done lots of work over this in the last few years. There are implementation projects now all over the UK, and you're going to hear about some of them in a minute. Also in Western Australia, and also in South Australia now, they're putting this pathway in at a community level. And we've done a lot of work over more than a decade in South Asia, doing something very like this in an adapted form in India, Sri Lanka, and Nepal. And these things work cross-culturally, and that's important to know for our own multicultural society. So we hope this improves access to care. So I'm just going to finish by talking a little bit about our formal NHS evaluation in Manchester. And this is going to be complemented then afterwards by my colleagues, Kate and Jane, going to talk about other implementations. This is one that we've done over the last few years of the model as you've heard it, with the research evidence that you've heard, and then saying, well, how can we put this into practice in the NHS? Does it work when you put it into practice? Is it feasible? Is it effective? And the highlights from our implementation, which have been basically in Stockport, in South Manchester, and what we've had is a couple of comparison sites, which have been Central Manchester and North Manchester, which haven't had the pathway. So it's been a bit of a sort of not experimental, but a proper design, scientifically designed test. So there are two sites that haven't had it and 2 sites that have, and we've shown the differences. So the key sort of messages from this implementation over the last few years. Firstly, this detection technique that with SACS-R is feasible in training and implementation across multiple professional groups. This was the key first hurdle. Can we get health visitors, care workers, community nurses, pediatric nursing staff, frontline workers essentially trained up in this? Would they be willing to do it? And would it work? And the answer is yes. It took some energy and time and convincing people to change what they're doing, but once they started, they were enthusiastic. The frontline staff like it. And one of the key things that's good about the SACS in practice is that it does identify really efficiently where there is an increased likelihood of autism trajectories early on. So it does identify that, but it also clarifies when concerns are not around an autism trajectory. And we all know in practice how many, especially now, cases get referred with problems that really are nothing to do with neurodiversity and autism. Particularly after COVID, that was the case as well. And SACS is good at identifying when it's not a problem. And that's really important for the efficiency of services. So this kind of approach does not overwhelm services. That's a very important finding. So in this community study in Stockport of 600 families, over 600 families, using the SACS, there were 8 SACS positives out of 600. This represented about 1.3% of the population approached who had opted in, right, after they'd opted in. But the whole population identification was about 1.3%. And that is about what you'd expect from the population prevalence that we know around autism. So basic message from this is that this does not like suddenly overwhelm services with identifications. This seems to be quite efficient, and the numbers identified are feasible for the care support to be provided. And this is the other big practical concern that managers had. Well, we won't be able to have the provision when you identify all these cases. But in fact, this is containable in the pathway if you train up people to deliver the care. So that's the first finding, is that this detection piece of the pathway looked successful. The next bit that we thought is a key outcome, and we were really pleased with, is that we've halved the wait list. And as I said before, this was an important practical, pragmatic outcome from this, that we stopped having families sitting on waiting lists, stewing with anxiety and racked with concern about their child. And what we've done in this kind of way of combined detection care is that we've reduced the numbers of families on the wait list for diagnosis by 50%. And we've also reduced the wait time for families who are on that wait list to get the assessment they need. So both of those have been roughly halved. And, you know, this is an important result pragmatically, we think, in a situation in the health services where wait lists have exploded. There have been then a lot of reports, outcomes, responses from families, from the autism community about their experience of this. And, you know, these have been very moving and positive overall in terms of what families have experienced. And, you know, here you can read for yourselves. And I know Jane and Kate will be talking more about these kinds of family experiences in their own practice. But I particularly like this one of an autistic mother after working in PACT with her own autistic child. So this is intergenerational. And she's really saying, you know, what I learned is how I wanted to be treated as a kid. And that felt very powerful to me, that of this sort of relational effect of this kind of approach, and the children feeling heard, and the parents feeling that they can support their child to feel heard. If only my parents have had this when I was young. So you'll hear more about this as we go through. We also looked at embedded clinical outcomes. So if we're going to evaluate how well this kind of thing works, we have to do it in a way, not in research measures, but in just the way that everyday services, you know, record and track their outcomes. So we use goal-based outcomes, which are very PROMs, which are very prevalent in health systems. The Sheffield Learning Disability Outcome Measure, which is just a way of a kind of PROM related to specifically learning disability, developmental conditions generally. And then for some of the cases, we have this interaction tally, which was a way for us to look at the parent-child interactions in a bit more of an experimental way. You know, most services won't do this, but we wanted to really look to see how the parent-child interaction was happening in practice. So goal-based outcomes, you know, really overall have shown in all the places we've done this that these have improved. And these are parent report, of course, on what mattered to the parents. And these are just indicative results that show you when you use PROMs, you do get indication that this has been positive outcome for families. This is the when we do the video, like we have done some sort of video assessment of the interactions with some of our families. And what we show here is that the parents are responding in the same way as we showed they did in the trial. And that was really reassuring. So it suggests that what we found in our clinical trials, which of course are in a really kind of rarefied way, when we actually do this in real life, in practice, on the ground, in messy reality, actually you get the same effect, that parents improve their responsiveness, use of contingent language. And crucially, we also see the same effect of the child being more socially engaging, motivated, initiating interactions. And we see that also in the everyday practice. These are crucial results for us who've done the clinical trials because, as I said, they suggest, yeah, this does actually translate across into everyday practice. And we showed that the SACs, we've been able to shift the SACs, which suggests that the children's autism trajectories are being optimized in a useful way. Parent confidence and understanding is also improved. And there's lots, I'm only giving you sort of overview data here, but we had lots of data on parents' sort of confidence and understanding of their child. And it was nice to see that they were feeling more confident and empowered. This is one that says, I feel I understand my child's behavior. And you can see this is the change from baseline to endpoint. We also, just to finalize, did a qualitative study, which in quite a structured way, because I wanted to report this to NHS England, who funded us for this. And we did a whole load of semi-structured interviews with different stakeholders, including parents, leads, managers, and clinicians, etc. and we did a formal thematic analysis. And this also was fairly encouraging, I think. For the managers, you know, they want to get the waiting list down. That's their big priority. So they were very happy that we'd done that. For the clinicians, generally, what we were doing here fitted with clinician values, which is important. Clinicians got the idea about early detection intervention, although they were skeptical initially that this would actually be possible. But you know, clinicians have realized actually when you make this shift towards a anticipatory work, it is a shift that actually, wow, it works. There are, you know, important issues which we can come to in discussion about staffing and, you know, how you can do this pragmatically. And parents, we've already said, like no more worrying for 2 years on a wait list. You know, these are really important outcomes for families. So the lessons from the implementation is you just have to get on and do it. Yeah, there is a challenge, an uphill challenge at the beginning to shift the whole model from reactive to anticipatory. These are system changes, and like any system change, this takes time, perseverance, and encouragement for the change, and to doing it strategically. It needs perseverance. And some systems are more ready for change than others, but you know, this is collectively, all of you on the call today, you know, I hope we can think about this collectively as an important change in approach across all our practice in the UK and internationally. I've already said that we're trying this out. Well, we're doing this in the UK and in South Asia and in Australia. So we've got experience in different places of putting this in place. Every place will be different. It'll require the initiative, the creativity, the enthusiasm, the passion of local people to make this kind of change and put this kind of thing in place. And you're going to hear that from Kate and Jane after me, examples of that. But that's what it's going to need. And all of you on the call, I'm sure, will have those characteristics, but also questions that we can address. So that's what I want to say. And I want to thank all my wonderful colleagues who've worked with me in the huge clinical trials we've done as a background to this, and our funders. This is the iBasis and the PACT collaborating team, particularly Catherine, my wonderful colleague who's worked with me through all these years on this. And in our most recent implementation, the wonderful people in Manchester and Stockport who have believed in this and pushed it through. And, you know, that has been a wonderful thing. So this is our most recent acknowledgements at all levels of the system. And as I say, you'll hear from Kate and Jane how they've pushed this forward in their own areas. So thank you so much. There's lots of background info, as you'll know, if you're interested. And here's some of the linkage websites. Back to you, Catherine.
Thank you, Jonathan. And I'm sure you'll all agree with me that was a really comprehensive presentation. Wonderful to hear that, bringing together all of the key science, the evidence, and how it's effective and its implementation, and the feasibility, I think, is just really impressive. And I think, you know, what's really important is the astounding rigor of those scientific trials, which is no mean feat. They are absolutely enormous machines to manage, and Jonathan has steered this successive research to a very, very high rigorous standard, so that we can be confident that we know that the guidance that's developed from that successive research is extremely rigorously grounded and gives us confidence in our practice. And so often, you know, we hold, I think, such strong views of our own, all of us, and our belief systems, and science doesn't always come out with the results you expect. And it sometimes comes out with something surprising, but what happens is you get one small thread of evidence and you build on it and you work it through and do cumulative scientific trials, as Jonathan has led this level of quality of science, and it in the end leads to something that's highly informative and really valuable to clinical practice. And talking about efficiencies, this is where, you know, we can all feel confident in moving forward in our service delivery models by anchoring it on such rigorous evidence. So thank you very much, Jonathan. I thoroughly enjoyed that, and I'm sure everybody did. It's just really inspiring to everybody for moving forward. Just quickly, before we move on to the next speakers, some people have been posting questions about how can we get access to the training and how can we get that information and the training costs. So just to say that the website, 3W's info, 3W's pacttraining.co.uk, that's the website where information will be on that website as it becomes available. So at the moment you can find information on PACT training on the website, the costs, what it involves, the stages of the PACT training. And if you also email us on info@pacttraining.co.uk, we can gather your names of those that would be interested in SAXAR and iBasis training. And as soon as that training becomes available and we can roll it out, we can let you know of those training courses. So now moving on, it's with great pleasure that I'm going to introduce first Kate Lemon, who's a leading speech and language therapist at Oxford NHS Foundation Trust, and her colleagues, Katy Willis, who's a speech and language therapist, and Liz Murphy, who sadly can't be with us, but we've got a recording from Liz. And they'll share their experiences of working with families in different settings, with the support of care workers and specialist teachers. And it's quite an impressive demonstration of the proactive NHS service expanding into how they've delivered PACT. And they've progressed from just having 2 professionals trained to now having a whole team of therapists who are trained delivering this service. So I'm going to first of all share screen, so just bear with me while I upload the PowerPoint. There we are.
Thank you so much, Catherine.
Over to Kate.
Thank you. Yes, we're going to talk about PACT within speech and language therapy service in Oxfordshire. We've been working with families, working with settings, and working very, very closely with our colleagues in education. The specialist teachers have been working alongside us. So next slide, please. Thank you for sharing the slides. Okay, so we're going to run through sort of how we began our PACT offer in Oxfordshire, and then how we've gradually grown our team, the training we've rolled out, and the supervision that we've put in place to really keep our skill set high. How all this fits in within our social communication pathway, and then how we've managed to sort of embed the ethos of PACT within settings using a tool that's been developed by Helen Delagi in North Wales. And then our vision, where we hope to go next. Next slide, please. Okay, so just to set the scene, during COVID, there were really large numbers of children on the caseload with social communication differences who really needed support. We've seen and we continue to see a significant increase in referrals for children with social communication differences. And just to explain as well, lots of these children, they're autistic children, but they're not all. So they come in for triage, and then we're looking at all of the children who have these needs. So terminology is a little bit waffly, I'm sorry, but hopefully that's okay. We wanted to offer evidence-based intervention that would have a lasting impact, and we wanted to really move away from the model of the therapy being delivered directly to the child, but rather through empowering the most important people in the child's world. We're wanting to enable parents to be able to tune in even more to their children. As the experts, they're the experts in their child, validating their child's interests, their ideas, their communication, and then through that increased understanding, creating more opportunities for connection with their child. Next slide, please, Catherine. So initially, our clinical lead, Sarah Ray, had discovered PACT through a systematic review of the research and was really keen to bring this approach to Oxfordshire speech and language therapy. So in 2021, managed to gain some funding to send one of our Band 6 specialist speech and language therapists, Katy, Willis, who's talking with me today. So that was an initial pilot project. We're starting with 5 families in that July. There were still COVID restrictions then, so actually the remote offer was really, really helpful. Next slide, please. So overwhelmingly positive feedback from that initial pilot. One parent emailing just to thank Katy, reflecting specifically on their new awareness and how they'd been able to improve their interaction with their child and could see that their child was much happier as a result. So then if we move on, please, next slide. So then we managed to ramp up. So I was employed in April 22 in a hybrid role. So I work predominantly remotely, and I'm just delivering PACT digitally to predominantly families, sometimes settings. But the key here, which was really great, was that I'm also a PACT trainer. So I've also been able to roll out training to my colleagues in Oxfordshire NHS, and to do that relatively cost efficiently because I've been able to do it on my NHS time and all of that supervision within my NHS time. So we've sort of had a stepped rollout. So in the October 22, trained 4 speech therapists and 3 of our speech and language technical instructors. So essentially speech and language therapy assistants. And we've been trying to work really hard to keep this balance of speech and language therapists and speech and language therapy technical instructors. And I'll talk a little bit more about that in a minute. October 23 then trained another 5 speech and language therapists and another 1 assistant. And then in May 24, another 8 speech therapists and another 1 assistant. We've always made sure we've got that balance of speech and language therapists who are available to support and to supervise and guide our assistant colleagues. If we could go to the next slide, please. Okay, so now we have 17 speech and language therapists trained within our team and 5 assistants. And we've tried to plan that really carefully so that we've got speech and language therapists and at least 1 speech and language therapy assistant in each of our 6 areas. So Oxfordshire is a relatively big county, sort of in the middle southern part of England, for anybody that's not in the UK. And over that 2 years, we've only actually lost 3 members of staff due to role changes or moving out of the area. And one colleague has recently come back to work for us again, which is great. So we're retaining our staff that are PACT trained, which is also brilliant. Next slide, please. Okay, so just talking a little bit about the skill mix. We just knew that our speech and language therapy TIs had extensive experience of working with children with autism. They almost always had previous relevant career experience as well before coming to work for us. And they just had that magic ingredient of being able to really build good relationships. And we felt confident that the format of the PACT training being so rigorous would enable staff to transition from that more directly working with a child to being able to empower the adults around that child through video feedback. And of course, our technical instructors, and I think it's important to emphasize this because it's been a key part of our rollout. They have more clinical time on the ground, so they're not running assessment clinics. Their report writing is minimized, so they've got more hands-on time. So we really wanted to build them into our offer to make it work. So next slide, please. Okay, so Liz Murphy, who wasn't able to present with us today, is just sharing a little bit of her experience about delivering PACT. Thank you. Oh, I think maybe you haven't shared the sound, Catherine, sorry. You might have to reshare the slides with the sound, please. Thank you. No, still not working. I don't think there's any sound on that. Sorry, Catherine. Oh. Okay, maybe we could come back to that in a moment. So the benefits of the remote offer. There's limited parking available in our clinics in Oxfordshire, and the travel time for families is quite significant because it's such a big county as well. We wanted to be able to reach families that don't have access to a car and aren't able to afford to travel. And a lot of parents have huge anxiety about coming into a clinic setting with their autistic child, because quite often that is a really anxiety-provoking situation for the child as well. What we were able to do with the remote offer is make that PACT appointment much more family centred. So we could kind of manage it so the child wasn't there, but potentially maybe even both parents can join if both parents are available, or a parent and a grandparent. Sometimes we have a parent and a nursery on that call together, but essentially having the child not there, organising it when the child's in school or nursery is just so much easier for the parent to be able to have that moment to reflect on their interaction and really to discuss and go on that journey of discovery. So we began during COVID as well, so that was a really essential element. And then if we go to the next slide, please. So for me, all of those practicalities are so important when you're delivering anything within the NHS. But for me, absolutely the biggest benefit is the natural kind of nature of the fact that parents are videoing their own play. So you just get all parts of the day. They might be bouncing on the trampoline together or playing in the park. It's part of their everyday routine. I've had videos of, putting gloves and coats and hats on ready to go to nursery. There are no barriers to generalizing because the parents starting that interaction within their own home. So, there isn't that context of, he likes playing in the clinic with those toys, but not at home. They're starting it in the home. And the absolute joy for me, I feel such an enormous privilege to have that window into their daily lives. And I think that enables me to support and see and go on that journey of discovery with the parent all the better. I had one video with a child sliding down a banister with a cheeky little grin because he knew he shouldn't be, stacking the spice jars on the kitchen floor or helping mum peel potatoes. They're not videos that you would be able to have within a clinic setting, but the natural nature of them within the home just really works for having those enjoyable connections. They're what the child has chosen to do and is enjoying sharing with their parent. So we go to the next slide, please. Okay, so just sort of a bit of the nuts and bolts. It's a remote offer. Parents record their own videos, they upload that to a shared document file and then share that to our NHS email address. We meet over Microsoft Teams. Lots of parents are now really, really familiar with using Teams since COVID, which is great. And we begin with 6 PACT sessions. That's our initial offer. And then next slide, please. And then also, we are flexible. Of course we are. We need to meet the family's needs, whatever that looks like. So we also would offer home visits. If a remote offer wasn't going to work for a family, maybe their Wi-Fi wasn't sufficient, they weren't confident doing a video call. And that really is where our technical instructors really come in, because they've got more time on the ground. So they would be able to go and do that PACT session as a home visit, or we could invite them to clinic if that's what the parents wished. And of course we use translators where we need to. And you know, if it's not the right time for that family, for whatever reason, there's lots of things going on at that moment, we'll find somebody else where we can support around the child, so that we might offer PACT to the setting, to the key people working with the child in the nursery or in the school. And we're always thinking about what's going to work best. So it always has to be centered around the child and the family. Next slide, please. Okay, so obviously, like everything, there are some challenges. Some people do have poor Wi-Fi. It's really tricky to manage that. But like I said, we've got the flexible offer. And I think the biggest challenge is the difficulty that parents have recording on their phone, recording the play, because little people quite often do want to get hold of the parent's phone. But normally we can talk that through. We can find ways of navigating the challenges. And I have to be really honest as well, we do hold a very long wait list at the moment. We are working towards reaching families sooner, but I will I'll put the numbers in on the next slide. Next slide, please. Okay, so I talked about we don't offer an initial 6 sessions. So after 6 sessions, and these are qualitative outcomes, we're looking you know, to plan to sort of gather this more scientifically. But after 6 sessions, what we're seeing is a significant shift in well-being, both the child and the parent. The child is seeking more moments of shared attention from their parent and choosing to stay longer within those interactions. There's a lot more initiation, lots more communication initiation, and sort of initiating that they really want that attention. The child is showing more understanding, more awareness of the world around them. And parents just finding it much easier to understand and interpret their child's communication. And that life within the family has just got that little bit easier. There's quite often a shift in play, so the little person becoming more curious, exploring their toys more, maybe if they're in nursery, navigating more of the different areas of the nursery rather than staying in their one sort of favourite area, just being more confident to explore. And we do continue up to 12 sessions if we need to. So again, we're being flexible. If we have a child with more, you know, slightly more complex needs, more significant needs, or maybe it's taking a little bit longer to build that understanding and discover all the right things that are going to create that connection, then of course we're going to carry on. But actually after 6 sessions, it's about empowering, isn't it? Parents saying, actually, do you know what? I've got this. Can I contact you if I need to in a few minutes? Absolutely, you can. You know, so it's about empowering them, feeling I've got this. I am the expert. I do know how to support my child. Next slide, please. Okay, so a little bit of context around our social communication pathway. The referral comes in, and we triage that really carefully. Then the first step, and I think this is really pivotal in parents understanding that they're the key agent of change. We're not going to fly in, we can't, unless they want me to move in, which I'm sure they don't. They're the key people in their child's world. Absolutely they are. They know their child better than anybody, and they're going to be the agent of change. And that message from the beginning in the parent workshop, where we just talk about those foundation communication skills, little things they can do at home, we encourage them to maybe have a go at videoing and reflecting on that play. We then follow up, and that's a bit like a telephone kind of initial call, really getting a feel for where the child is at, where the parents are at, and discussing what options are open, and then potentially, hopefully at that point, offering PACT as our first port of call following that parent workshop. And that can be in setting if need be, if it's not appropriate for parents in that moment, or we might go in and train the setting up with May I Join You, which my colleague's going to talk about in a bit more detail in a minute. And then also, obviously, some children are a little bit more complicated. Their needs are more complex. We need to work that out. So we'd invite them for a social communication assessment clinic where they'd come and meet a colleague in person. So just to give you some context, we currently have 1,108 children either waiting or on our social communication pathway. And that's not including the children who've already kind of processed through this little bit and are now receiving support for their social communication needs within our locality areas, within one of our 6 areas. I also want to mention as well that children do not need a diagnosis to access PACT within Oxfordshire. They don't need an EHCP to access our services either. So we are very much open. We want all of the children that need our support. There aren't too many sort of gates, not too much gatekeeping, if that makes sense. We really want to reach all of the families that need us. Next slide, please. Okay, so I talked a little bit about this. We are really hot on clinical supervision, both one-to-one supervision being available whenever needed, and fortnightly supervision for our speech and language therapy technical instructors. And then we do a group PACT clinical supervision every 4 weeks. And we obviously people work different days, so we make sure everybody can attend at least every 8 weeks so that everybody's bringing cases and discussing, sharing video clips, and just really keeping that high standard within our clinical skill. And next slide, please. So I just wanted to talk a little bit about why we love delivering PACT within the NHS. It works. It really, really does work. I think as a clinician, to be able to have the privilege of going on that journey with a family, to create that lasting change, it is a huge privilege. It really is. And it's not just for the little autistic person and their parents, but the wider impact of that. I had one child where he couldn't manage when his brother's friends came round, but after we'd done PACT, actually his brother had the whole football team round and he was quite fine with that. You know, they're big things, aren't they, within a family, to be able to have those big changes. Next slide, please. This is my favourite quote from a colleague, just really talking about how it's so lovely to be able to deliver an intervention that has such a positive impact within a relatively short space of time. And how you see those really quite sometimes big, sometimes little differences and changes that it makes to everybody's life within that family. And it is hard to put it into words how much but why we enjoy it. But the reason I'm emphasising this is because staff retention within the NHS is a significant factor. We are losing staff to the private sort of independent therapy sector. So I think, you know, to have a therapy that is not only works and it's got an incredibly rigorous evidence base, but also therapists enjoy delivering it. And, you know, I really love my job more than I can tell you. Next slide, please. And then I think we can go to the next one again, please, Catherine. So within Oxfordshire so far, we did a bit of a tally. We've had clinical system issues, so it was a bit of a count-up, but we've worked with 210 children, the adults surrounding 210 children, and that's including parents, carers, nursery staff. We know we've delivered training to many more. Katy will talk about that a little bit. And it is only me that's got I do 3 days now where I just deliver PACT, but all of my other colleagues who are amazing are delivering PACT in between all of the rest of their clinical work. So, you know, it's great. We've got a really fabulous team. So I think it's the next slide now, please, Catherine. And then I'll hand over to my colleague, Katy.
Good morning. So once we had delivered PACT with a family and we had a lovely situation where the parents are empowered and the young person is seeking those interactions with their parents because the parents were so in tune, we realised that we didn't have a way to support those children once they were in a setting. And unfortunately, it's just not possible at the moment for within the NHS in Oxfordshire to deliver PACT at home with a family and then to go and deliver it in setting. So we needed another way to roll out the PACT principles as effectively as possible. Next slide, please. And Helen Delagi had already realised this back in 2016 and had developed a resource called May I Join You? This is a bilingual resource in English and Welsh, which aims to develop the understanding of how you tune in and develop shared attention and early communication skills in small children with social communication difficulties. This resource is specifically aimed at skilling up the people who support autistic children in nurseries and school. There is a handbook, a video and effective training available. And if you want to find it, this is what it looks like on YouTube, which is where it is freely available. Next slide, please, Catherine. So we have rolled out May I Join You training in Oxfordshire, and the sort of key elements are developing the understanding of social communication differences. We watched the video and it shows key strategies that are likely to enable staff to tune in more sensitively to the children in their setting. And then as part of our training, we have role play, and everybody role plays. And this is one of those moments where people have real light bulb moments. So that you're a child or a grown up or the person who's supporting the grown up in the role play. And it's amazing what comes back in the feedback when people are talking about, oh, I didn't realize how annoying it is if the adult talks over me, but when I was the child and I'm looking at a shape, really frustrating. And so it really helps embed the things that we know through PACT, really help people tune in to the child. It helps the staff to realize this. And then an extra bit that we've wanted to add in is, in the settings, if the staff can bring a video of themselves with the child at a moment, just like the parents do on PACT, we look at it with them and all the staff, and we look at the positive things they're doing to support that communication and really help them see what they are doing. Just like in PACT, you do that with the parents. And again, this is another moment where their learning really gets embedded and they start to do this in their day-to-day life when we're not there. Next slide, please. So a typical journey for a child entering our service is they arrive and they have what we call specialist support, which is PACT with the parents, or in setting if the parents are unable to do it. And then we deliver May I Join You training to the setting. And we have a sort of embedded version of this, which we're trying to do in every setting, where once they've had their training, the child's already had PACT, the setting has its training, and then we put the TIs in to do 4 more sessions with the specific children on our caseload and their key workers, and they film those children, the key workers, and bring that to a session with the TI just to get even more practice at spotting what they're doing that's so fantastic to support that child, so that they can then do more of that in the coming weeks. Once all this has happened, the children move to targeted support, which is a minimum of 4 visits a year. And again, we're going in offering further advice and support as needed. And if they haven't already had May I Join You training, or if staff change in settings, we can do more May I Join You training. And then when everything is in place and everyone around the child is feeling really skilled at being able to support the child, we discharge them, and this is the end of their episode of care. But just reflecting on what Jonathan said earlier, this isn't discharge and goodbye. This is discharge, but you can come back at any point, and we have a fast track system for those children who are already known to our service. So at this point, parents are usually super empowered, and they're saying things like, oh, I can go and talk to the school. I don't need you to be there doing that. But they're really happy to contact us if they need anything. So like maybe when the child moves to school or from reception to year 1, they might give us a call and say, well, could we just have a bit more speech therapy, please? And what you will hear in a minute is how we want universal support to always be available in every setting across the whole of Oxfordshire. And we are making really good progress with that. And as you can see on the bottom of the slide, a re-referral can be made by anybody at any point should there be more support needed in the future. Next slide, please, Catherine. Now, one of my great joys of working in Oxfordshire and working with PACT has been that we are so fortunate to work really closely alongside our colleagues in education, both the early years SEN advisory teachers and the communication and interaction teams who are based in schools. So in November 2022, we had a whole day with the iSenate colleagues where we looked in more detail at how we were supporting young autistic children and their families and in settings. And we took time and at home, and we took real time to share PACT and what Kate and I were doing with PACT, and how at that point we introduced the May I Join You resource. This has led to lots and lots of joint working. You can see all the times we've met and trained and talked, and those are just the big days that we're doing this all the time. And we are jointly delivering training now in settings all across Oxfordshire to deliver this PACT-based approach, PACT principles, May I Join You, across the county with all our families. And so the support goes on within schools and settings. And it has been one of my great pleasures to work with all my colleagues. So if we go to the next slide, we can see where we are now. So our advisory teachers are championing May I Join You for use with all children in all settings at the universal level. All our health visitors are aware of PACT and May I Join You across Oxfordshire and work closely with us. Our community paediatricians have had an evening where Kate went and talked to them, and they're incredibly supportive of our PACT work, and they talk to families about this when, you know, they're beginning to maybe say this child may be on an autistic trajectory. So we strongly believe that every child benefits from someone taking the time to tune in more to them during their play, to share in their interests. And we see this as a way of getting to know all our children better, and that all children will be developing their confidence to interact and communicate. Next slide, please, Catherine. But the journey doesn't stop there, because we're always trying to further develop our service and make it reach even more families. So we have just actually, since this slide was written, run our May I Join You training for parents of children in a special school. These are children that were in our service before PACT was here, and so they haven't had that experience. So they're in a special school where they've had, all the staff have had May I Join You training, and it's rolled out as a universal strategy. But we felt it would be really nice for parents to know what was going on. And the evening was a huge success, and we are now about to pilot one in a mainstream primary school in a couple of weeks' time. And again, it's a school where the staff are already using and have already been trained with May I Join You. And then our other big dream is to grow the capacity to offer PACT to older children who were in the service before Kate and I were here, where possible. Next slide, please. And then our vision, I'm very excited about our vision, so I'll try and keep it brief, but I would love for every family with a child with social communication difference to be able to access PACT under the age of 3.5. We would really love for May I Join You to be in every single early years setting in primary school within 2 years. So it's universal the minute a child walks across that door, because we still have some children turning up in school where no one has suggested that they might have communication differences. And the first time we know about them is when they arrive in reception. So I would love for this to be just what every school is doing. For the same in special schools, that May I Join You will be universal the minute your child walks through that door. So the support kicks in straight away. There's no difference from what you've been getting at home to what you're getting in school. And then we really want to embed May I Join You and PACT principles into our EHCPs in collaboration with our educational psychology colleagues. We are liaising and sharing our work with CAMS, and Kate and I would really like to develop hard evidence for the impact of 6 PACT sessions. Next slide, please. So thank you very much for listening. Please post your questions in the chat.
Thank you, Kate and Katie. That's a really inspiring presentation, and wonderful to hear how you've grown your service. It's very impressive. But also to hear how you've extended that liaison with education. So it's not just a health-based service, that's of generalising the principles across all care contexts for the child. And I think that's, fantastic that we're getting that better understanding and awareness in terms of sort of validating the young person's neurodiversity, helping little children, young people develop their identity from an early age in a way that all adults around the child have better understanding and know how to support their individual profile and identity in a way that enables them to flourish. And that's the aspiration, for this to be not just a drop in the ocean, but for it to be a much more cohesive, embedded support framework in which young children can be themselves and flourish and develop. So fantastic presentation. So sorry that video didn't work. We didn't have sound. We will look into that and maybe find a way of posting that video with consent on the website so that everyone can have a look at it after this webinar. So now we're going to move on to our next presenter. So this is Jane Case, a Senior Programme Manager at Greater Manchester NHS Bury, alongside her colleague, Debbie Walker, a Director at First Point Family Support. And they'll discuss their implementation of PACT within their service offer and share really powerful insights and parent testimonies I actually, when I saw this before, I found these personal stories really brought to light the reality for parents. I think you'll see that, hear it in their voices, see it in their faces, where they are, and the heartwarming sense of what they gained from receiving this early support. So I'm really delighted that their service are also planning to progress and integrate SAXAR, and being our really important partners in rolling out iBasis to complement the whole autism care pathway alongside their other family support, which is really valuable for as a sort of drop-in centre for parents. So I very much hope you enjoy listening to them as I did. And I'm going to hand you over now to the two presenters, Jane and Debbie.
Thank you, Catherine. Hi, everybody. As Catherine said, my name's Jane Case. I'm a programme manager in Bury, but I'm also a parent of two neurodiverse children. Well, they're not children anymore, they're 28, but we've been through the system. And I think as a commissioner, I always think about what would have made things easier for families who have been through a similar pathway. And hopefully, as we go on and talk around what we've done in Bury today, you will see the passion that Debbie from First Point and the First Point team have actually brought to the mobilisation of our needs-led approach, which we're trying to really build on in Bury. So I'll just share my screen with you now. Okay, so this is basically our journey throughout Bury. And it started in 2021. That's when we already had some pre and post diagnostic support that was provided by First Point and CAMS. But what we knew is that it wasn't enough. And so we started holding a series of focus groups with parents. And they very much shared their journey with me. And it was heart-wrenching, to be honest, because they basically told me that they felt bereft on a waiting list that could last over 2 years. And they said that there was too much focus on diagnosis, and not that they didn't want the diagnosis, because they did, because that was the key to getting support, and we really needed to turn that on its head. So we started to think about not diagnosis-led but need-led approaches. We also recognised that because we had two pathways, we had an under fives pathway and an over fives pathway, there was no joint ownership across the system. So as a commissioner of the whole service and system, it was about bringing us together and recognising that we all owned the outcomes for these families. And we really needed to address those long waits for diagnosis, and we recognised that we needed to do more. So we spoke to parents and we said, what would help you whilst you're waiting? And they spoke to us around several different ideas, and we've put some of those into action. So we'll share some of those with you later on.
Excuse me, Jane, I
Can
can't see the slides.
Oh, sorry, you can't see it. Let me go back, I'll stop sharing. Come on. Sorry, I thought you could see that. Can you see that now? Yes, can you see that now? Let me put it on full screen. Yeah. Okay. Can someone tell me if that's better?
Yes.
Great, thank you. Okay, so I've already spoke to this slide. I'll go on to the next one, but you didn't see it, sorry. Oh, it's not letting me share the next one now. Let's see. There we go. So as I said, we held a series of focus groups, and these are some of the things that families shared with us. It was highly political. There was a lot of a huge number of complaints. Parental dissatisfaction was high, and there was poor communication between the system, and there was very little engagement and interaction with early help. And of course, as I said before, the diagnosis was the opening for additional support. We really needed to turn that on its head. And of course, Jonathan's already spoken about it. When we looked at it, the huge numbers of children on our CAMS waiting list that didn't have a moderate to severe mental health issue, they were waiting for neuroassessments, and it was at least over 80% of children on our CAMS waiting lists. So we started this work in 2021, and we really wanted to turn it from a medicalised view of SEND and additional needs into a needs-led and social view of SEND. So we started that paradigm shift from disability to diversity, from diagnosis to needs-led, and we started thinking about how do we meet that need earlier and better. And we looked at our clinical pathways, and we identified, alongside those people who knew the child best, because what we found is the diagnosis pathway really didn't capture any of that. It was very much process-led. We really needed to bring early help on board, and we're still doing some of that. So our journey is not yet finished. As Catherine said at the beginning of this presentation, we're still building our system response. And we wanted to enable families to have things that could help them. And when I've finished this presentation, I'll put some links into the chat for people to see some of those things. So what we did is we reviewed our offer, and we looked at best practice nationally and regionally. And we got involved with the GM developments. So there was lots going on at a GM level that Berry were not a party to, but we very much put ourselves around that table, and very quickly we started adopting those things. So we looked at and we brought on board Riding the Rapids for school age and teens. We looked at PACT. And for us, it was how do we develop that Thrive approach to support? So ensuring that people who need advice and guidance would have robust advice and guidance. When people needed to get help, that they got it, and when they needed more help, that was there for them also. So we worked predominantly with First Point and CAMS, and we looked to develop our wider offer. What was interesting was when we started looking into PACT, because we read all of the research, we were saying this has got the evidence base. We did find out that there was one speech and language therapist trained in Berry, but because of the wider system pressures, they didn't have time carved out in their work plan to deliver PACT. But what we then realised that we had to step up a system or a service that would deliver PACT, because they were already engaging with these families. And so we looked at who was already in that space, and it was First Point. They were already supporting families with neurodiverse children, and we're doing an awful lot, especially around the Thrive framework, to support them. So when we were able to, we secured PACT additional funding and training, and really bolstered the team with regards to what they could do. And we chose PACT because it was evidence-based intervention, like Riding the Rapids. For us, it was we needed to bring in those things that we knew would have the most impact and influence the most change across the whole system. So Debbie will go into more detail around how we've rolled out PACT and why it's made such a difference, and why, because they are specifically placed as a third sector voluntary organisation, that they're able to roll it out and influence and shape early years practice as well as school-based practice. And it's just really benefited us, it really has. As I said, we're still progressing with our journey. We've got SACSAR and IBASIS training, which will take place this year, and we'll start rolling that out. And again, we've looked around who engages with these families, who's already in that space. So we're really lucky in Berry. We have a range of SEND health visitors and nursery nurses who do developmental checks. So we're looking to train up them in SACSAR and IBASIS as well as First Point, because of the reach that they have with those families. And we're also expanding our Riding the Rapids early years offer. The other thing that we've done is we've developed a range of Padlets to support families. So if you think about the Thrive quadrants, we've got advice and guidance around supporting your neurodiverse child, supporting sensory needs in your child, and supporting ADHD in your child. And within those Padlets, there's a range of information that looks at sleep, emotional regulation, anxiety, general parenting support, as well as other diverse areas. So I will put that link in. The other thing that we have done is, and it's part of that culture change, is we are on board with the National Autism in Schools programme, as well as the PINS programme. So we have 9 schools in total this year, 5 going through on the PINS programme and 4 going through on the Autism in Schools programme. And we're slowly changing the culture in Berry, as I said, from that diagnosis driven to that needs-led provision. The other things that we're developing and moving with is a neuroprofiling tool that's happening at a Greater Manchester level, but we are bringing that to Bury. And again, what's really heartwarming for us is if anyone's read the Children's Commissioner report that came out last week, it really endorses the needs-led approach and the drive and determination that there is across Greater Manchester to do something different, because we know this pathway doesn't work. We know it really leaves families in a vulnerable position, and so we want to change that. So that report, whilst it was quite damning of the waiting lists and what's happening, it also strongly endorsed all of the things that we're trying to do. So that was good for us. Because it really gives power to our change mechanisms, and we are progressing with a lot of that. So I'm talking about Bury, but there is GM work that's happening around this as well, so it's really good for us. But I'm going to hand over to Debbie now, and Debbie will take over. And Debbie, I'll put your slides on, just tell me when you need me to change them.
Thank you, Jane. Good morning, everybody. My name's Debbie Walker. I'm a company director at First Point Family Support. Just to give you a little background, I was a registered general nurse for 25 years, and within that time I also co-founded First Point Family Support Services. And I too have lived experience to have a young man who is an adult, a young adult with complex needs. And just to say, most of our workforce here are very passionate and have lived experience too. Most of our workforce are either parents or siblings of either a chaddle as I call them, or an adult with complex needs. So yes. So yeah, we are a third sector organisation. We're a not-for-profit limited company, and we've been established in Bury for 14 years. We've always had a needs-led approach. And what, alluding to what Jane was saying, is that we've always done for a long time now a post-diagnostic offering Bury for parents who have children diagnosed with autism or ADHD. Those families were automatically referred to us from CAMS or paediatrics, and we were missing a pre-diagnosis offer in Bury. And just to say also, we were already working with the Thrive framework at First Point. Okay. Yeah, so we already have, I mean, I could go on all day about the Thrive model and what we offer in each sector. If anybody would like me to send that, I will send that. But just briefly, getting advice for each of the quadrants, getting advice would be surgery drop-in, signposting, educational seminars, plus a whole host more. The PACT came in at the getting help part, where we offer one-to-one support. We offer the PACT as a pre-diagnosis offer, as well as the post-diagnostic offer. And we also have PACT in the Getting More Help quadrant. And then obviously we're linking with our colleagues at CAMS for the Getting Risk support. Jane. Okay, so we had no evidence-based intervention at the time. We only knew about riding the rapids. And then in early 2021, we heard about PACT, and we were extremely keen to be part of this. And we wanted it as part of our offer at First Point. As a team, we had training in November 2021 in lockdown, and we started actually delivering PACT in May 2022. We started really small with PACT, but because of the evidence, we quickly realised the impact we were making. And I always get emotional when I say this bit, but the impact wasn't just on the families, it was also on the staff team. And then obviously, due to the results and what we were seeing and what we were feeling, we absolutely were passionate about this. And we absolutely further wanted to develop our team. Jane. So how does the PACT work? So Kate's kind of done this really well, so I'll just really briefly cover this. So it's obviously a partnership between the professional and the parent carer. And what it does, it draws on the individual positive attributes and builds on with the parent's relationship with the child. And this leads to a better understanding of the child and enhances parents' ability to accommodate and adapt to their individual differences. And throughout the process of this, through play, the child will learn to initiate communication on many more occasions, which positively affects their overall ability to interact, meet needs, and self-advocate. And as Kate described earlier, the PACT therapist uses video feedback techniques in order to work in this way. Thanks, Jane. In practical terms, so before starting PACT, the therapist will offer an initial meeting just to discuss the child's development and current strengths and needs, and they'll also ask about their experience of the family. In Bury, we do it a little bit different, Kate, in Bury. I know it's a different, the offer can be 6 sessions, 12 sessions, but in Bury we do 12 PACT feedback sessions, and at each session a short video around 10 minutes is reviewed of the parent and their child interacting or playing together. The short videos are made and sent to the therapist in advance, as Kate already discussed, and obviously, as Kate was saying previously and her colleagues around, it's really, we have to make lots of, we have to be really flexible with this. Parents work in different ways. There may be language barriers. We have to make sure we're doing that at how the parent feels comfortable. And sometimes we have to work a bit extra to get that first video going, or how we do this. That's really important to point out. We're not just expecting people to jump into it and be confident. This is a work in progress. And whilst you're doing this, we do this anyway, don't we? But we're building a therapeutic relationship with the family. Thanks, Jane. So the time commitment. So PACT sessions will last around an hour, and families will see their PACT therapist for 12 sessions every 2 weeks for 6 months. They'll be asked to do 30 minutes of daily practice. Now, people might be thinking, oh my God, that seems a lot. It's not, because they end up doing it anyway. They end up, it's part of their natural life and their natural day-to-day, practice. It might start off staged and parents overthinking how they do things, but it doesn't carry on like that. They absolutely get into it. And families can continue with support and care from health, education, other services, and it can go alongside speech therapy. Jane. So where do we get our referrals from? So in Bury, we have referrals from, we have a resource provision nursery in Bury, local authority nursery, so it makes sense we get our referrals from there. We also have referrals from our early years team in Bury and our strategic lead, and also from within our team, because obviously we also do family support for social care, school nurses, as well as CAMS. So we obviously have families we're working with constantly, so we have places as well. So our current numbers for PACT are, they're not as dynamic as Kate yet, but we have 16 families currently open to us. We've had 35 referrals from the beginning of May 2022 to now. This year we have 16 places available, 5 from Hoyle, the nursery, 5 from the early years, and 6 for First Point families, which 4 have been used. We also have 10 places being offered for CAMS starting in September this year, and this will increase to 20 and 25. So slowly but sure, we're building up. So how we support, we also, we now offer ICB support and mentor other areas in the Greater Manchester area. So we have certain days where we have a helpline, and my colleague Nicole, who leads PACT, who's unfortunately on holiday right now, hence I'm here, she supports the various teams in practical ways and gives advice as best she can. So why are we so invested? Because it's absolutely massive. As a parent, when I was a parent many moons ago, what we were offered as a family was the Hannon course. That's absolutely nothing like this. It's absolutely groundbreaking. And as a PACT therapist, I can't tell you how rewarding it is when you see a penny dropping moment of a parent when they realise how they need to change things and do things differently. And it's not criticising parenting ever. It's about enhancing that parent because they know that child, and it's about how you show them a different way to get the best from their child. And I can't say it enough as a parent and as a PACT therapist how life-changing PACT is. I know I sound dramatic, but I really do mean it. Okay, Jane.
Okay, Debbie, I'm just going to stop sharing because I need to change over so that the audio comes for the video clip. So I'll just share again. But you're right, Debbie. What I've heard today so far is the golden thread throughout all of this has been the rewards for the practitioners and the family and everybody who gets involved in PACT. It's just so amazing. But as Debbie said, we're going to share some of our lovely parents and staff who've worked on PACT.
Hi, my name's Nicole Blaze. I am PACT lead at First Point Family Support, and I've been delivering PACT to families with both verbal and non-verbal children since September 2022. When I first heard of PACT, I thought it sounded amazing. To be able to do a therapy where it focuses on play and communication through play was something that I hadn't heard of before. And I think play is a key way to look at how a child communicates, how they think and how they process things. And for a parent to be able to look at that too is amazing. I think the commitment of PACT can seem like a lot at the beginning when it's first explained to parents, but from practice so far, a lot of my parents have said that having to spend 30 minutes a day set time just with their child has really benefited their relationship and their communication together. Going through a day and through your daily routine, they've been able to spread it out and they've really enjoyed the commitment so far. I think the biggest difference for a lot of families is building that shared attention with their child, learning to sit back and focus on how the child is playing, how they're trying to communicate through that, and then being able to engage with each other at the level of the child has been amazing. I'd definitely recommend PACT. I think the differences that we've seen from session 1 to session 12 with lots of families has been phenomenal, and I've had lots of families say that it's reached beyond their wildest expectations of where they thought their child could be, and the relationship between them and the child having that better understanding and being able to communicate on a much better level.
Hi. I first heard about PACT through the head of provision at my son's primary school. She said that First Point were offering therapy sessions to families of children with communication difficulties, and she thought that our family would be a good candidate. I like the idea, so I asked to be referred. My son is almost 7 years old. He is verbal. He has limited expressive language, no conversational skills really at all. He is echolalic, and he also scripts with his speech. He was about 12 months old when I first noticed that there was some sort of communication difficulty. The few words that he did have had completely disappeared, and he barely made a sound. No eye contact, didn't seek attention, and he had no non-verbal communication at all. We've been doing PACT since January of 2024. You have to be committed when you do PACT. It can be a tad difficult at times, but I find that being consistent and doing it every day, even if you don't manage to do the full 30 minutes, is the best way to go. You also have to be flexible, because there are times when we don't do the 30 minutes at all in one day, so you can't put too much pressure on yourself. But yeah, consistency is the key, I think. PACT teaches you to interact and communicate through play. The feedback sessions that I have with Nicole are extremely helpful. It helps in showing me things that I do well during play, things that maybe don't do as well, and it's also good to sort of like guide you and help you improve on your communication skills and seeing and reading your child a little bit better. And sometimes having that third person is extremely helpful. So yeah, that it's good. We enjoy doing it. It's definitely made a difference in our day-to-day life. My son is definitely more descriptive with his speech. His listening and understanding seem to have improved quite a lot since we first started doing it. He's recently had a speech therapy session when he's gone back to school, and his speech therapist is like over the moon with his progress. You can't believe how much progress he's made in the last few months since she's seen him. His teachers are noticing it as well. He requests more, and he'll request more than one thing at once, which he's never done before. That's like a recent thing, so that's been really good. And he's now, when we're doing the PACT sessions, he's now beginning to show the very beginnings of back and forth conversation, which I didn't think that we'd ever have, in all honesty. So it's been fantastic, and yeah, it's been brilliant. I definitely recommend it to other parents of children who have any sort of communication difficulty. It's fun. Your child doesn't know that they're doing therapy, so that's like really good. And you've nothing to lose, really. You get out what you put in. But like I said, it's enjoyable and it's fun, so it's not like you're doing therapy at all. And it's helped me understand my son a lot more, and it's created a nice bond. We now play every day, which we hadn't used to do. So yeah, it's been brilliant for us. It's been fantastic, and we can only see things improving. So thank you so much. Thank you very much. Bye.
Hello. So I first heard about PACT through my son's school. He's 8 and he's non-verbal, and school decided that it might be a good idea to put me forward to see if it would be beneficial. When I read about it and heard about it, I was a little bit nervous because I didn't think we'd be able to achieve what it was asking. But Nicole has been fantastic all the way through, explaining everything to us, and I'm really surprised that we've managed to hit our targets quite quickly. I've really enjoyed learning how to engage better with my child, which in turn has increased our time together. It's also been really interesting listening to an outsider looking in, and then being able to hear things that we don't hear on a daily basis, picking up on those words and being able to reinforce those words with our child, who has now gone from probably saying 3 or 4 words. He's probably hitting 20 or so, and most of them are in the right context as well. So I would definitely recommend giving it a go to any families that have got children that are verbal or pre-verbal or are struggling a little bit. It's definitely really helped us as a family. I was a little bit uncertain as well with the duration of it, and the commitment and being able to arrange it around work and things like that. Fortunately for me, work have been really flexible, and Nicole has been amazing at being able to reschedule if something has cropped up that I haven't been able to attend. So yeah, I would definitely recommend it to anybody. Give it a go, even if you are skeptical like I was, thinking no one's been able to get my son to talk, this isn't going to help, but I'll try it for him and then I can say I've tried it. Well, it's working and I'm really enjoying it, and I can't wait to see how he develops throughout the rest of the course.
So when I first heard about PACT, I wasn't really sure what it was. It definitely sounded interesting because always desperate to try and find any way and extra support to help with my child's communication. My little boy is 3.5 and he is non-verbal, diagnosed with autism, sensory processing disorder and global developmental delay. I noticed, and our health visitor noticed around 8 months, that Charlie had social communication difficulties, and he was referred to SALT, I think around 12 months old. We've been doing PACT now since the end of May, so about 3.5 months. The commitment really is not very much at all, because you agree on your objectives, and they ask you to do 30 minutes per day, but actually you're playing with your child for over 30 minutes a day and engaging with them anyway. So we just embed it into his normal play, what we've done before, and what our new objectives are. It's made a massive difference to our child. He's now trying to communicate with us, mostly non-verbally, but because he knows that we're listening and understanding his cues, he is making more attempts to communicate with us, which has an impact on his emotional health, reducing his frustration and things like that. It's great. Day-to-day life, he is expressing himself more. He's taking adults by the hand and leading them to where he needs to be. So just because he can't say it, he knows that if he does that, the parents or a trusted adult in nursery will respond. I would 100% recommend it to families to do, because even looking back at the first videos that we did, he was trying to communicate with us. He really was trying to communicate with us all along, and it's really helped us sort of decipher his communication and then build on it. And it's helped with his play. It's made him less apathetic about things. He's more bothered about things, and all I wanted to get out of it was I wanted to play with my child. I wanted him to be understood, and he's done that for us.
Okay, so in the future we're looking at I-basis, which is 11 age, and we'll look at our offer. Jane, I don't know if you want to.
Sorry, Debbie, there's a little bit of an echo.
I think it was because I had the sound still on there. But yeah, I'd agree with you, Debbie. We're still growing our offer. As I said before, we're bringing in early help. We're looking at what our universal parenting offer should look, what it should look like. We've got fantastic opportunities to build our early support around our we're not going to call it an ND hub because there's hubs everywhere, but it will basically be our early support hub for children, young people and families who have neurodiverse children. And again, First Point is central to all of that as well. We do have some testimonies that we can put up on the screen if you want, Catherine. And I did say that I would share some resources in the chat, so I'll pop the resources in the chat, and then maybe put some I'll put the written testimonies in there as well. Okay, so I'll share my screen again, and then it's over to yourself, Catherine, if there's any other questions that people have got.
Catherine, you're on mute, I think.
Thank you, Jane and Debbie. This brings it alive as a reality, the real experiences of parents, but I think also, that the experiences of the child, that listening to the child, even if the child can't verbalize themselves, their non-verbal speaks volumes.
Yeah.
They are able to give their own testimonies in their way, the way they show themselves, the way they engage and interact, and what they show us. So I think that's giving even little children, even before they're verbal, that opportunity to express themselves and be heard. It's so powerful. I love the testimonies. from the parents. And I love the fact that, you know, your service is so embedded in actively listening to what parents want. And also within your team, you have people with lived experience. So, you know, you're very connected to what the values and aspirations of the neurodiverse community. It feels like a service that's very connected to listening. And the fact you've been able to transform your service so radically by listening, and it's been so achievable for you and with such great outcomes. It's just fabulous. So it's very heartwarming for me, and I'm sure, you know, for all of us that have put an enormous amount of dedicated time of our lives really into seeing this need and really wanting to passionately progress services to improve the quality of lives for autistic young people. So all, you know, fantastic presentations. I think they've all flowed very nicely together. Just to remind everybody who's listening that if you have colleagues who weren't able to join us today, this is being recorded and it will be posted on the PACT website. So just again, that's the 3 W's, PACT training, all one word, .co.uk. And if you have any problems connecting to the website, please email us on info@pacttraining, all one word, .co.uk. And we hope with consent, we'll be able to share those lovely videos as well. And we would really appreciate your help in sharing these presentations today as widely as possible. We want as many people as possible to hear the evidence and hear the rollout and implementation as a result of this evidence. So now I'm just going to, we're on time, just fantastic. So we've just got 10 minutes left where we've had some questions coming through online. And unfortunately, I don't think we can address all of them, but we can have a good go at addressing some of them. So the first question I'm just going to direct firstly to Jonathan, but then also to Jane and Debbie, is about funding streams for training. People are saying, where do they secure funding streams to get the training? Jonathan, do you want to talk through how what the work you've been doing with Greater Manchester and nationally, widely?
Do you mean funding streams for training or for putting the pathway in?
It just says funding stream for training. I'm assuming that's training on FAXAR, IBASIS, PACT.
Yeah, I mean, I think I'm not the one to answer this really. I mean, the funding is going to have to be, developed locally, isn't it? I mean, what we're advocating for and trying to develop is a national initiative which does have some funding attached to it. But as you can imagine, that's a tough ask at this point. But that NHS England and the National Autism team at the NHS England are, I mean, they did support our implementation in Manchester financially. They gave us some pilot funding to do that, and they know about our results, and they are very supportive of this approach. So what I'm kind of working towards at a national level is whether some central funding can be identified, a bit like IAPT. So my sort of ambition and hope would be that we could get training of this kind through IAPT. Now, actually, it is already available within IAPT. So there is an autism learning disability IAPT training program. The problem with it at the moment it's not as well funded as previous IAPT initiatives. And really there's the pathway to do this through IAPT training. And those of you who are familiar with IAPT will know that this was a sort of national resource to backfill staff to get trained up in new therapies. Still exists, it still happens. All it needs is the extra funding stream to allow better backfill. So that, to me, is the most realistic form of national support for something like this. But then, apart from that, it's finding local supports, and obviously that's up to you locally. But I'm focused on the national.
Perhaps I could ask Jane then how you managed to find funding to fund the PACT training.
Yep. So I was able to access transformation funds that were held at Greater Manchester. And as I said, there's been huge amounts of work done across the last 2 years in Greater Manchester to redesign our neuro pathways and to look at what innovation we could bring in. So when I started looking at how we could change our approaches, we applied to our senior commissioner, and we were one of a few areas who were able to secure different additional funds to run with it. What's been really fantastic is because of the impact it's made, that has then meant that CAMS have also commissioned. So I commission PACT from a locality perspective through the GM monies that I secured as a commissioner, but then CAMS have also commissioned. So we've been able to layer up and increase our offer incrementally as we grow. And that's why we've been able to then also look at developing our reach and moving towards IBASIS and SAXR before the end of the year. So that's really positive for us.
Okay, one for Kate. How easy was it to train a range of professionals in delivering PACT?
Sorry, what was the question? How easy was it to train?
A range of professionals from different backgrounds. I think you've trained some speech and language therapists, but also some
I think the PACT training is so rigorous. I think as long as you've got that experience and you're open, I think that's the thing, isn't it? Having that open attitude to sort of working with families in a different way, not directly with the child. I think, we've trained all sorts of different professionals, haven't we? I think it is. I think the PACT training is rigorous, and it is easy, I think.
And if I could just come in there, Kate, I think it's really interesting the way you've grown your model from speech and language, but I knew I couldn't do that in Bury because our speech and language wait times were so pressured. And that's why, for me, it was, as I said in the slides, who's in that space already, who's got that capacity, who's engaging with these parents. So I would encourage people to think really creatively when they're thinking about who needs training up in PACT, because the testimony from our parents was so moving, and they all related back to the work that the team have done, but in particular Nicole, who is a sibling. She's got that lived experience, and what she brings is like you and your colleagues do, that passion comes to work with her every day. And I think that's it. If you get passionate professionals who are keen and engaged, train them up in PACT.
Definitely.
And we do encourage that skill mix, so that we've got a team of different professionals who can work together within the same team, and can have that ongoing support and supervision to maintain a high adherence to the quality of PACT, so that it represents the research evidence that's behind it. I think we've probably got just one more question, and this is I'm just going to direct this again to Jonathan about there have been a few questions about the difference between some of the interventions being mentioned. So, there's been Hannon, May I Join You? Sometimes we get other interventions, and PACT, and the implications in terms of this holistic service, but about the evidence. How does this link to the evidence? What is important in the difference between some that may be disseminating a PACT-like approach and those that are targeted PACT?
Well, it's the difficult question to answer, briefly, but as I said at the beginning, the unfortunate situation is that most of the sort of healthcare responses in an autism context currently in use don't have much demonstrated evidence. That doesn't mean that they aren't good and certainly well-meaning and may be effective. I mean, the absence of evidence doesn't necessarily mean the evidence of absence, if you know what I mean. Doing these generating the evidence is hard, demanding work. I think but it's true throughout healthcare. If you compared this sort of situation with, I don't know, diabetes or any kind of health condition, what we would want for our loved ones and our families is an intervention that has been evidenced as a safe, effective, cost efficient, etc. I mean, that is, what we try and do within clinical science and healthcare development. And of course, there will be many initiatives that have grown up because there's such a demand. But, it has to be the case that it's best to focus on those that have strong evidence, particularly if they're feasible to introduce. And, it's also been shown in, lots of ways across healthcare that evidence practice is cheaper in the end. I mean, that's really important. I mean, it's not any more effective, it's cheaper because it's more effective. So that's all I can say. Obviously, I come from a particular position, having generated the evidence, so I'm invested in it. A lot of the other interventions mentioned some of them have some evidence. I mean, Hannon has, for instance, most group-based approaches like Hannon, although it's a sort of a bit of a mix, but it's essentially, group. None of those kinds of group approaches have ever shown an effect on long-term child development. They are helpful for families, for morale, for parent good feeling, and Hannon, I think, would be the case. But as you heard from one of our other contributors, PACT is individualized and it's rather different, although in some ways the sort of basic principles are similar, but the actual implementation is very different. And because it's individualized, that seems to me, and the video feedback nature of it, to be key to its success. And what I mean by the success is the fact that it impacts on children's lives downstream in development. And I think that is a crucial difference between an individualized support and group-based. Group-based work is good, but you have to be, and it's good in its context and it's good at what it does. It's wonderful to have often the support of other parents and individuals in a group, etc. So I'm not downplaying that at all, but to get real change in child developmental outcomes and experience is hard in development. And there isn't the evidence at the moment that we've got is that group-based interventions don't do that. It's just not intensive enough. So that's one thing I'd say, but I don't want to do down other kinds of approaches that have been produced. People have to make their own judgments. And let's, let 100 flowers, 1,000 flowers bloom, as long as they really show their effectiveness, and that's really important. But so I wouldn't want to dilute what we know has good evidence, and this, of course, is why we have the NICE committee, which did meet in 2013. It's a long time ago now, but and did support this kind of approach as saying this is worth considering, and that's why we have these kinds of health service, evidence-based practice initiatives. So all I can do is advocate that as being more effective and better demonstrated.
Thank you, Jonathan. really helpful. Kate has got her hand up. Kate.
I was just going to come in and say, I think, absolutely, I completely agree with everything you're saying. And I think in Oxfordshire, we've talked a bit about that May I Join You approach, and that's literally helping adults around the child that's already had PACT tune in more. It's not instead of PACT, is it? It's about just skilling up other adults to kind of, and then the child's already had PACT, so they're already communicating more, they're more motivated, they want to kind of engage a little bit more. So then you're just kind of widening that. I guess that you're supporting the communication environment around the child, aren't you? But it isn't PACT completely. It's completely different approach, but it works because the child's had PACT. I just wanted to drop that in.
Yeah. Okay, well, thank you everybody for your just fantastic presentations. Just fantastic to take away all of the content and wonderful testimonies and linking the science with the feasibility of implementation. And I hope everybody who participated and attended has enjoyed it. We haven't been able to answer all of your questions. I apologize for that, but we will go through those questions one by one, and we will post our collective answers on the website. So please do visit the PACT website, and please do feel free to share the video recording of this presentation. And thank you very much for your support and your valued participation. And we look forward to hopefully hearing from you through the website chat, and if you want to email us with any questions. So thank you very much to everybody, and hopefully we'll be in touch soon.